Okay, we are back for studying. We're going to do some self-testing and review now. I want to see... Oh, does the stream go back on live? Let's see. One second. One second. One second. Okay. Can I go back on stream? Okay. Hello? Okay. We are back. Okay, let me see. Does this actually... if I go to my channel, what does it look like? Oh, it starts a new one. Okay. Okay, got you. Okay, that's fine. We have a new stream. Let's... Okay. Okay. I'm almost done. Okay. Stream is ready to continue finally. Okay. So let's talk about not microbiome right now. Let's do self-testing and review with the neurology section of... This is first aid. This is like their checklist thing. This is like first aid for the USMLE. Okay, step 1. Okay, first I want to see the tracts actually. And then we're going to hopefully do a bunch of questions. So this is neurology and special senses. Let me just remember again. I should draw this. The forebrain to the telencephalon, diencephalon, and then thalamus, hypothalamus, retina, and cerebral hemispheres, basal ganglia, and then midbrain, pons, cerebellum, medulla. This is actually a good one because I know there are going to be some, like one question maybe like this. So let's do some review and self-testing. So here we have this. I'm going to try to make that. Okay, so I'm going to go Excalibra. I really like this one, Excalibra.com. It's very good. Okay. So with that, this one's really good. So let's try to remake that document. Okay, so I'm gonna make the three things. Okay, of the embryo. Okay, 1, 2, and 3. Okay. Next, let's put the... Okay, so this is gonna be This is going to be from, let me just put this is anterior. Well, actually, it should be caudal and rostral. Caudal, rostral, okay? What's caudal versus rostral again? Okay, cool. So the first one we have the prosencephalon. Okay, the next one, this is going to be the, so that's also known as the forebrain. Forebrain, midbrain, hindbrain, okay. And then the prosencephalon, this one is the mesencephalon. And this one right here is going to be the, what is the last one called? Oh, rhombencephalon. Rhombencephalon. Okay. And then these differentiate. So this one's going to become two things. Okay. So this is going to become two things. Okay. And those two things are going to be, this is going to differentiate into two things. So I'm pretty sure the telencephalon is here. And then, of course, this goes into its own thing also. And then this also. And I'm pretty sure this turns also into two things. Okay. So we have the telencephalon here, and then what is this one called? Diencephalon, maybe? The diencephalon. Okay, so the mesencephalon becomes okay, so I know this one becomes cortex, basal ganglia, lateral ventricles. Okay. What about the telencephalon? I think it becomes, actually, it's hard to say, because would the thalamus be part of the basal ganglia? Let's actually make this cortex and lateral ventricles. This can be basal ganglia, thalamus, and the third ventricle. Okay. Okay, so I'm pretty sure the rhombencephalon. Is this going to be the medulla? Okay, time to look. Forebrain, midbrain, hindbrain. Okay. Oh, the mesencephalon just says the mesencephalon, and then the hindbrain becomes the metaencephalon and the myelencephalon, which then becomes the medulla. Oh, and the pons and the cerebellum are from the metaencephalon. The midbrain is from the mesencephalon, and then the thalamus and hypothalamus and the retina, okay, come from the diencephalon. Oh, and the basal ganglia and the hemispheres are from the telencephalon. Okay, so telencephalon, diencephalon, mesencephalon, metaencephalon, myelencephalon. So telencephalon is the first, di is 2, the rest are arranged alphabetically. Mesencephalon, metaencephalon, and myencephalon. Okay, got you. So telencephalon, diencephalon, cortex, basal ganglia, lateral ventricle, then we have the diencephalon. Then it follows alphabetically. Mesencephalon, encephalon. Okay, so actually, so this is going to be metencephalon. This is going to be myeloencephalon. Encephalon. Okay. Okay, and then the mesencephalon is actually going to be the midbrain and the aqueduct. Midbrain and aqueduct. Aqueduct. Okay. The metencephalon is going to become the pons and the cerebellum. So pons and cerebellum. Okay. And then, of course, the fourth ventricle is going to be made from, like, different parts of these, okay? And then let me get the arrows. So from the metencephalon, we get pons and cerebellum, and then the myeloencephalon, we get the medulla, okay? Is that good? Okay, and telencephalon is first, and then it follows alphabetically: diencephalon, mesencephalon, metencephalon, myeloencephalon. Okay, let's just be sure. Midbrain, cerebral aqueduct, metaencephalon, and myelencephalon. Okay. And then let me just make sure the pons and medulla, pons and cerebrum come from the metaencephalon. Okay, let's clear the canvas and do it again. Okay, I'm gonna do it again. Okay, so we're gonna have forebrain. Okay, this. Okay, so let's start. So forebrain is a prosencephalon. Okay. Midbrain is the mesencephalon. And lastly, we have the hindbrain, the rhombencephalon. Okay. Next, the forebrain is going to range into two, so we're going to have telencephalon, and then alphabetically diencephalon. Okay, and then mesencephalon is going to stay mesencephalon. Okay, and then the hindbrain is going to become the metencephalon, and the myelencephalon. Okay, finally, we're going to have more differentiation. So we're going to have, from the telencephalon, we're going to have cerebral hemispheres. We're going to have, what else will we have? Basal ganglia and lat ventricles. Okay. Okay. From the diencephalon, we're gonna get the hypothalamus, thalamus, and we're gonna get the aqueduct. Okay. Okay, from the mesencephalon, we're going to get just the midbrain. Midbrain, and we're going to get... Oh, sorry, the aqueduct is here. This should be the third ventricle. Okay. Then from the metaencephalon, we're going to get pons. Okay. Okay, one part will be pons. One part will be, what's the between, oh, cerebellum. Pons, cerebellum, and then finally the myelencephalon becomes the medulla. Okay? Okay, and then let's draw the arrows. Okay, that's nice. So I'm just gonna export this. I think I got this okay. And then the questions will actually test my knowledge. So let's export this, embed the scene. This is gonna be called neural tube brain dev. Okay, and it's gonna be a PNG. Okay, perfect. So let's see what else we can do. Stuck. Okay. Let's see what else is in store for us. Okay, this is a good one. Regionalization of the neural tube. Actually, I should make... Can I make quick notes on here? I don't know. No. Annotate note. Okay. We deleted the note. I want to add a note here. How do I annotate note again? Okay. Control Command N. Control Command. And, good. Okay. And I'm just going to put this as screenshot. Maybe. No, I'm just going to put this as a note. How about that? And that's going to remind me that, you know, this is one that I really pay attention to. Okay. Okay, in the alar plate is dorsal sensory induced by bone morphogenic proteins. Basal plate is ventral motor induced by sonic hedgehog. Same orientation as spinal cord. You know, I could continue on just like quickly reading all of these. How long is the neural section? So it goes all the way to 550, 560, 570, 572, 574, okay? And where does it start? Okay. Oh. What? Hold on. Is it really that much? I guess it is. It's a lot of pages. Huh. Maybe just as I go through it, the ones I don't need, I won't pay attention to. Okay. So I'm going to continue on with my neural notes. Okay, now I'm continuing on with the neural notes. Can I put a bookmark here? I don't want to trim. Okay, so this is neurology, but this is from the notes form of first aid, so it's going to be more abbreviated, okay? So I'm going to start with neural development. Notochord induces overlying ectoderm to differentiate into neuroectoderm and form neural plate. Notochord becomes nucleus pulpulus of intervertebral disc in adults. Neural plate gives rise to neural tube and neural crest cells. Lateral walls of neural tube are divided into alar and basal plates. The alar plate is dorsal. It is sensory. It is induced by bone morphogenic proteins, BMPs. And the basal plate is ventral. It's motor induced by sonic hedgehog. Okay. So I guess, I don't know how to remember that, but same orientation as spinal cord. Okay. So the alar plate is dorsal. The basal plate is ventral. Already did the regionalization of neural tube. We got that down. Okay. Central and peripheral nervous systems origins. Neuroepithelia neurotube is central nervous system neurons, central nervous system glial cells, astrocytes and lingodendrocytes, ependymal cells. Neural crest is peripheral nervous systems. Neural crest is parasympathetic nervous system cells. Dorsal root ganglia. Peripheral nervous system neurons like dorsal root ganglia, autonomic ganglia, sympathetic, parasympathetic, enteric, peripheral nervous system glial cells, Schwann cells, satellite cells, adrenal medulla. Mesoderm equals microglia, like macrophages. Oh, interesting. Okay. Neural tube defects. Okay. Neuropores fail to fuse by the 4th week of development, leading to persistent connection between amniotic cavity and spinal canal, associated with diabetes and folate deficiency during pregnancy, increased alpha fetal in amniotic fluid and serum, except spina bifida occulta. That's a normal AFP. Let me also, I realized, I should get my chat here. Yeah, this one. But I should pop out this live chat. Okay. Let's put it here. No. Oops. Here. Okay, that in case anyone's talking, I can reply to them. Okay. And then let's not show sidebar. Okay. Okay, so neural tube defects are associated with diabetes, folate deficiency during pregnancy, increased alpha fetal protein in amniotic fluid and serum, except for spina bifida occulta, which is a normal alpha fetal protein. Increased acetylcholinesterase in amniotic fluid is a helpful confirmatory test. Okay, spina bifida occulta is a failure of caudal neuropore to close, but no herniation, usually seen in lower vertebral levels. Dura is intact, associated with tuft of hair or skin dimple at level of bony defect. Meningocell is meninges, but no neural tissue herniating through the bony defect. Myelomeningocele is meninges and neural tissue, aka cauda equina, herniating through the bony defect. And myeloschisis is also called racheschisis, exposed, unfused neural tissue without skin or meningeal covering. And anencephaly is failure of rostral neural pore to close, no forebrain. You have open calvarium. Clinical findings is polyhydramnios, no swelling center in brain. Got you. Okay, and then we have this nice diagram of normal versus spina bifida occulta versus meningocell versus myelomeningocell. I don't feel like I need to make a figure of this. Okay, brain malformations. These are often incompatible with postnatal life. Survivors may be profoundly disabled. So you have holoprosencephaly. This is a failure of forebrain prosencephalon to divide into two cerebral hemispheres. Development field defect usually occurring within weeks 3 to 4 of development, associated with sonic hedgehog mutations, may be seen in Patau syndrome, trisomy 13. Fetal alcohol syndrome. It presents with midline defects, monoventricle fused basal ganglia, which is the star in A, cleft lip palate, hypothyroidism, cyclopia, proboscis, increased risk for pituitary dysfunction like diabetes insipidus. And you can also have lissencephaly. This is failure of neuronal migration leading to smooth brain surface that lacks sulci and gyri, associated with microcephaly and facial anomalies and hydrocephalus. Okay, interesting. Okay. This is good. Carry 1 and carry 2. So these are posterior fossa malformation. So carry 1 malformation is ectopia of cerebellar tonsils inferior to the foramen magnum. It's one structure, usually asymptomatic in children, manifests in adulthood with headaches, and cerebellar symptoms associated with spinal cavitations like syringomyelia. Carry 2 malformation is herniation of the cerebellum, the vermis tonsils, and medulla. So it's 2 structures. Okay, cerebellum and medulla. Through foramen magnum leads to non-communicating hydrocephalus, more severe than Chiari-1, usually presents early in life with dysphagia, stridor, apnea, limb weakness associated with myelomeningocele, usually lumbosacral. Okay? Then we also have Dandy-Walker's malformation. This is agenesis of cerebellar vermis leading to cystic enlargement of the 4th ventricle. That fills the enlarged posterior fossa associated with non-communicating hydrocephalus and spina bifida. Okay, syringomyelia. This is a cystic cavity syrinx within the central canal of spinal cord, which are the yellow arrows. Okay, fibers crossing in anterior white commissure, the spinothalamic tract, are typically damaged first, results in cape-like bilateral symmetrical loss of pain and temperature sensation in the upper extremities. Fine touch sensation is preserved. It's associated with Chiari-1 malformation, which is right here, and which shows low-lying cerebellar tonsils, scoliosis, and other congenital malformations. Acquired causes include trauma and tumors. Most common location is cervical, then thoracic, and then lumbar. These are syringomyelias, and syrinx equals tube as in syringe. Okay. Oh, this is a good diagram. Kind of. It could be better. Okay. And then it shows the expanding syrinx in the middle of the central canal of the spinal cord. Okay. And you have that cape-like formation problem. Okay. Continuing on. Let's see. Tongue development. I feel like the genie comes out of the lamp and stuff. I mean, I feel like this is a nice diagram showing taste and sensation and the cranial nerves. Okay, so the first pharyngeal arch forms anterior 2/3 of tongue, sensation via cranial nerve V3, taste via cranial nerve 7. Okay, and then third and fourth pharyngeal arches form posterior 1/3 of tongue, and that's when you're going to get sensation and taste mainly via cranial nerve 9, and the extreme posterior via cranial nerve 10. Okay. Motor innervation is via cranial nerve 12 to hyoglossus, retracts and depresses the tongue. Genioglossus protrudes the tongue, and styloglossus, it draws the sides of the tongue upward to create a trough for swallowing. Okay, so the genie comes out of the lamp in style. So genioglossus comes out, it protrudes the tongue in style. And style is, I guess, styloglossus. Okay, which makes the trough. Okay, motor innervation is via cranial nerve 10 to palatoglossus. Elevates posterior tongue during swallowing. Okay, so cranial nerve 10 innervates the palatin glossus. 10 for cranial nerve 10 and 10 for palatin glossus. I can make this, I can do self-testing and review on this kind of diagram. Arch 1 is basically, taste is facial, and then sensation is V3. But then all the way at the back, we're having taste and sensation from 10. And in the posterior, like 1/3, we're going to have cranial nerve 9, I guess, giving taste and sensation. Okay, I wonder, is this like high yield enough to like make a thing on it? I don't know. Okay, I'll think about this one. So let's put a little note. Think note. Okay. Okay, maybe. Okay. Neurology, neurons. These are signal transmitting cells of the nervous system. Permanent cells do not divide in adulthood. Signal relaying cells with dendrites receive input. Cell bodies and axons send output. Cell bodies and dendrites can be seen on Nissl staining, stains, rough endoplasmic reticulum. RER is not present in the axon. Neuron markers include neurofilament protein and synaptophysin. Astrocytes, most common glial cell type in the central nervous system. Physical support, repair, movement, mobile, excess neurotransmitter, component of blood-brain barrier, glycogen fuel reserve buffer, reactive gliosis in response to neural injury. It's derived from neuroectoderm. Astrocyte marker is GFAP. Microglia is phagocytic scavenger cells of CNS, activation in response to tissue damage, release of inflammatory mediators, nitric oxide, glutamate, not readily discernible Nissl stain. It's derived from mesoderm. HIV-infected microglia fuse to form multinucleated giant cells in CNS in HIV-associated dementia. And then we have ependymal cells. These are ciliated, simple, columnar glial cells lining ventricles and central canal of spinal cord. Apical surfaces are covered with cilia, which circulate CSF, and microvilli, which help CSF absorption. These are derived from neuroectoderm. They are specialized ependymal cells, choroid plexus. They produce CSF. Okay? Okay. So these are basically all to do with CSF, the ependymal. And these are from neuroectoderm, microglia is mesoderm, and astrocytes are also neuroectoderm. Interesting. Okay. And then myelin is increased conduction velocity of signals transmitted down axons, saltatory conduction of action potential through nodes of Ranvier, where there are high concentrations of sodium channels. In CNS, including cranial nerve 2, myelin is synthesized by oligodendrocytes. In PNS, including cranial nerves 3 through 12, myelin is synthesized by Schwann cells. Got you. Myelin wraps and insulates axons, decreases membrane capacitance, increases membrane resistance, increases the space length constant, and decreases the time constant. Okay, CNS, oligodendrocytes, PNS, Schwann cells, so COPS. CNS, oligodendrocytes, PNS, Schwann cells. Okay, COPS. Schwann cells, these promote axonal regeneration. They are derived from neural crest. Okay, each Schwann cell myelates only one PNS axon injured in Guillain-Barré syndrome. Schwann cell marker is S100. Okay, oligodendrocytes myelinate axons of neurons in the CNS. Each oligodendrocyte can myelinate many axons, about 30. Predominant type of glial cell in white matter. Okay, continuing on. Derived from neuroectoderm, they are fried egg appearance histologically, injured in multiple sclerosis, progressive multifocal leukoencephalopathy, PML, and also in leukodystrophies. Okay. Those are oligodendrocytes which myelate CNS. Okay. Okay, this is an axon. I know the axon potential stuff. Yeah. Got you. Yes, that's fine. We don't need this. Okay. Sensory receptors. Okay. This is going to be a nice chart. So receptor type, free nerve endings. Sensory type is alpha, delta. And these are fast myelinated fibers. C are slow, unmyelinated, and A, delta plane is fast, but attack C is slow. Oh, a delta plane is fast, but attack C is slow. A delta plane is fast, but attack C is slow. These are located in all tissues except cartilage and islands, numerous in skin. They mediate pain and temperature. Meissner corpuscles are large myelinated fibers. They adapt quickly. These are located in hairless skin. They are dynamic, fine/light touch, low frequency vibration, and skin indentation. Pacinian corpuscles are large myelinated fibers. They adapt quickly. They are in deep skin layers, ligaments, and joints. These are high frequency vibration and pressure. Merkel discs are large myelinated fibers, adapt slowly. They are in the fingertips and superficial skin. They sense pressure and deep static touch. And then Ruffini corpuscles are large myelinated fiber intertwined among collagen fiber bundles. They adapt slowly. Fingertips and joints, they are found, and they do stretch and joint angle change. So basically, Ruffini corpuscles is stretch. Merkel discs is pressure. Pacinian corpuscles is high frequency vibration. and pressure, and Meissner corpuscles is low frequency vibration and fine touch. And then free nerve endings is pain and temperature. I could make a diagram for this, but it's going to be like pretty abbreviated. I mean, I guess these are not the highest yield stuff yet. Peripheral nerve. Okay, yeah, we know that. Endo, peri, and epineuron. Okay, that's fine. I can just read this quickly. So for the peripheral nerve, your endoneuron is thin supportive connective tissue that ensheaths and supports individual myelinated nerve fibers, may be affected in Guillain-Barré syndrome. Perineuron is the blood nerve permeability barrier. It surrounds a fascicle of nerve fibers. And epineuron is the dense connective tissue that surrounds the entire nerve, including the fascicles and blood vessels. Okay, chromatolysis is a reaction of neuronal cell body to axonal injury. Hold on, I'm going to be right back. BRB. And then I need a way to like I have returned now. Okay. Just gonna say back. Okay. 1 second. Okay. Let's see. Okay, let me start my voicing again. Okay, sorry. So chromatolysis is reaction of neuronal cell body to axonal injury. Changes reflect increased protein synthesis in effort to repair the damaged axon. It's characterized by round cellular swelling, displacement of the nucleus to the periphery, and dispersion of Nissl substance throughout the cytoplasm. You can also have Wallerian degeneration. This is disintegration of the axon and myelin sheath distal to the site of axonal injury with macrophages removing debris. Proximal to the injury, the axon retracts and the cell body sprouts new protrusions that grow toward other neurons for potential reinnervation, serves as preparation for axonal regeneration and functional recovery. I feel like this is not so important. I mean, it's good to see this pathology, though. Okay, this is literally, we saw this neurotransmitter thing, so let's read it again. Acetylcholine is in the basal nucleus of Maynard. In the forebrain, it decreases in Alzheimer's, Huntington disease, and it is increased in Parkinson's disease. Dopamine is in the ventral tegmentum in the substantia nigra pars compacta, I guess, or the substantia nigra, in the midbrain, and it decreases in depression. It's increased in schizophrenia. It's increased in Huntington disease, and it is decreased in Parkinson's disease. GABA is in the nucleus accumbens in the basal ganglia. It is decreased in anxiety and decreased in Huntington disease. Norepinephrine is increased in anxiety and decreased in depression, and it is in the locus ceruleus. And serotonin is in the raphe nuclei in the brainstem. It is decreased in anxiety. It is decreased in depression, and it is decreased in Parkinson's. I actually really like this. I really like this chart. So I'm gonna make this a note. Okay. So this is gonna be a note. Okay. Note. Okay. Good. This is good. Okay. So let's make it. Let's clear canvas. Sure. Okay. So honestly, does this thing have tables? No tables in Excalibur? Oh, I have an idea actually. Okay, and then we'll post it here. We will make a big okay, let's fill this out. Neurotransmitter changes with disease. So we have acetylcholine, dopamine, GABA, norepinephrine, and serotonin. And then we're going to look at location of synthesis, anxiety, depression, schizophrenia, Alzheimer's disease, Huntington disease, and Parkinson's disease. Okay, so let's make the arrows. Okay, acetylcholine. Let's fill out the areas of synthesis. Okay. Location of synthesis. Okay, let's do the ones I do know. This is the raphe nuclei. Norepi, GABA. Oh, this is norepi is in the locus ceruleus. Okay, GABA is in the nucleus accumbens. And dopamine is in the subtaxonia, pars compacta, in the basal ganglia. Okay. And acetylcholine, I have no idea. I forget. Okay. Acetylcholine is increased in Parkinson's disease, but you're going to have it decreased in Huntington disease, and I think in Alzheimer's also it's decreased. Okay. Depression, you're definitely going to have decreased serotonin. You're going to have... I don't remember these. I think in Parkinson's also you have decreased serotonin. Okay. Okay, schizophrenia, I think you're definitely going to have decreased dopamine. In depression, you're going to have decreased dopamine for sure. And in Parkinson's disease, you're going to have decreased dopamine. But when will you have increased dopamine? Decrease in Alzheimer's? And I'm not sure about GABA and norepinephrine. Let's look at this again. Okay. So dopamine is decreased in depression, it's increased in schizophrenia. Increased in Huntington's, but decreased in Parkinson. Meanwhile, okay, basal nucleus of Maynard. That is where acetylcholine comes from. It is decrease in Alzheimer, decrease in Huntington, and increase in Parkinson. Okay, and this is decrease in depression, increase in schizophrenia, that's dopamine, increase in Huntington, and decrease in Parkinson. Serotonin is decreased in Parkinson, it is decreased in anxiety and depression. And norepinephrine is up in anxiety and down in depression. So depression, everything is down basically. GABA is decreased in anxiety and it is decreased in Huntington's disease. Okay. So serotonin and GABA are always down basically, and in depression, everything is down. And that is a part of depression. And then basically it looks like in Huntington disease, dopamine and acetylcholine are in opposite directions, and same for Parkinson's. Okay? Okay. So basal nucleus of Maynard. Okay, so let me fix this. So depression, everything is down, so dopamine is down and serotonin is down. In anxiety, your norepi is actually up. And your serotonin is down in anxiety. Your GABA is going to be down in whichever things it's down in. Okay, but actually in schizophrenia, let me fix this. In schizophrenia, dopamine is up. In Alzheimer's disease, in Huntington's disease, dopamine is up, but is decreased in Parkinson's. And then let me look at this again. Alzheimer's only has acetylcholine. I just want to make sure these are the same. Oh, dopamine is the ventral tegmentum. I have to add that. So let's see. Acetylcholine is down for Alzheimer's, down for Huntington, and up for Parkinson. Okay, so dopamine is not in anxiety relevant. Okay. Oh, sorry. It is relevant in depression. It's down in depression. It is up in schizo. It is up in Huntington. It is decreased in Parkinson. Okay, what about GABA? GABA is down in anxiety. Okay, so GABA is down in anxiety, and it is down in Huntington. Okay. Okay, and serotonin is, okay. Yeah. So that's how it goes. Okay. So let's do it again. Basically cover it again. Okay. Okay, so I'm gonna do this again. Basal nuke of Maynard. Okay. Dopamine is ventral teg, and then substantia nigra pars compacta. GABA is nuke accumbens. Okay. Norepi is in locus ceruleus, and serotonin is in the raphe nuclei. Okay. Norepi is up in anxiety. Serotonin is down in anxiety. GABA is down in anxiety. Right. And let me just put it again. GABA is down in Huntington's also. Okay, serotonin is down in depression. And serotonin is also down in Parkinson's. Okay. Now for acetylcholine. Acetylcholine is basically up in Parkinson's. It is down in Huntington's. It is up in Alzheimer's. Okay. Next, so dopamine is decreased in depression. It is increased in schizo. It is increased in Huntington's disease, and it is decreased in Parkinson's disease. Okay. How did I do? Oh, I forgot norepi. Norepi is also, what else is norepi? Oh, it's down in depression. It's up in anxiety, but down in depression. Okay. And dopamine is down in depression, up in schizo, up in Huntington. Oh, and down in Parkinson. Oh, and then acetylcholine is down in Alzheimer's and down in Huntington. Okay, that's embarrassing. Okay, so let's change this first. It's down. Okay, next, GABA, no, norepi is down in depression. Okay, depression, everything is down. Okay. Okay. And let's just read through it one more time. Okay, so acetylcholine is the basal nucleus of Maynard in the forebrain. Dopamine is the ventral tegmentum and the substantia nigra compacta, I guess. GABA is the nucleus accumbens in the basal ganglia. And norepi is the locus ceruleus in the pons, and serotonin is the raphe nuclei in the brainstem. Okay, in anxiety, GABA is down, norepi is up, and serotonin is down in anxiety. So basically you have norepi up, but serotonin and GABA are down. In depression, you have dopamine down, norepi down, and serotonin down, everything down. In dopamine, you have in schizo, you have dopamine up. In Alzheimer's, you have acetylcholine down. In Huntington, you have acetylcholine down, but dopamine is up and GABA is down. In Parkinson's disease, you have, oh wow, dopamine likes to be special. In Parkinson's disease, you have acetylcholine up, dopamine down, and serotonin down. Okay. This was a good one. I could do it one more time, but let's do it one more time. It's fine. Okay, so let's do another one. Okay, so let's do this again. So this is basal nuke of Maynard. Dopamine is ventral tegmentum, SNC, GABA is nucleus accumbens. Norepi is locus coeruleus, and serotonin is raphe nuclei. Okay. Next, let's talk about, honestly, let's do arrows. Okay. So for depression, everything is going to be down. So I'm going to quickly say serotonin is down in depression, norepi is down in depression, and sorrow is dopamine. Dopamine is also down in depression. GABA is down in anxiety. I think GABA is down in one of these other diseases too. I think Huntington's is also down. Okay. In Parkinson's, dopamine is down for sure. Serotonin is down, of course. But acetylcholine is up in Parkinson's. In Huntington, acetylcholine is down, but dopamine is up. Okay. In Alzheimer's disease, acetylcholine is down. In schizo, dopamine is up. Right? Yeah, it's up in schizo. So down, up, down, down. Oh, forgot. Down. Oh, norepi, anxiety is up in norepi is up in anxiety, and serotonin is down in anxiety. Okay. Okay. That was good. This one is good. Okay. Blood-brain barrier, vomiting center. Oh, the vomiting center. Let me quickly read this. It's coordinated by the nucleus tractus solitarius, NTS, in the medulla, which receives information from the chemoreceptor trigger zone, CTZ, located within the area of postremia, pronounced puke strema, in the fourth ventricle, GI tract via vagus nerve and vestibular system and CNS. CTZ and adjacent vomiting center nuclei receive input through 5 major receptors: histamine H1, muscarinic M1, neurokinin NK1, dopamine D2, and serotonin HT3. Okay, 5-HT3, D2, and NK1 antagonists are used to treat chemotherapy-induced vomiting. H1 and M1 antagonists treat motion sickness, and H1 antagonists treat hyperemesis gravidarum. Oh wow, they have a whole sleep stages. Sleep cycle is regulated by the circadian rhythm, which is driven by a suprachiasmatic nucleus, SCN, of the hypothalamus. Oh, interesting. Where was dopamine produced? Did I misread that? No, it's instancy. Okay. So sleeping is driven by the suprachiasmatic nucleus of the hypothalamus. Circadian rhythm controls nocturnal release of ACTH, prolactin, melatonin, and norepi. SCN to norepi release to pineal gland increases melatonin. SCN is regulated by the environment, light. So 2 stages: rapid eye movement, REM and non-REM. Alcohol, benzodiazepines, and barbiturates are associated with decreased REM sleep and N3 sleep. Norepi also decreases REM sleep. Benzodiazepines are useful for night terrors and sleepwalking by decreasing N3 and REM sleep. Sleep stage, percent of total sleep time in young adults. So awake, eyes open is beta waves. Awake, eyes closed is alpha. Then for non-REM sleep, we have stage N1 is theta. Then stage N2 with sleep spindles and K complexes. It's when bruxism, tooth grinding occurs, and it's deeper. And then N3 is the deepest non-REM sleep. It's delta waves. Deepest stage delta, so D for delta, D for deep. Okay. So this is when you get sleepwalking, night terrors, and bedwetting. And then REM sleep is loss of motor tone, increased brain oxygen use, variable pulse / BP. REM is when dreaming, nightmares, and penile/clitoral tumescence occur, may serve memory processing function. Extraocular movements due to activity of PPRF occurs every 90 minutes, and duration is increased through the night. And these are beta waves. Changes in older adults, you're going to have decreased REM, decreased N3, and increased sleep latency in early awakenings. Changes in depression, increased REM sleep time, decreased REM latency, decreased N3, repeated nighttime awakenings, early morning awakening, terminal insomnia. Change in narcolepsy, decreased REM latency, and at night, bats drink blood. Oh, bats drink blood at night. Beta, alpha, theta, sleep spindles. Delta, beta. Beta, alpha, theta, sleep spindles, delta, beta. Bats drink blood. Bats drink blood. Bats drink blood. Beta, alpha, theta, sleep spindles, delta, beta. Okay? And that's for N1, N2, N3, and then REM. Okay. Okay, interesting. Ooh, this will be important too. Thalamus and the hypothalamus. Let's look at the thalamus nuclei. Major relay for all ascending sensory information except olfaction. Ventral-posterior lateral nucleus is spinothalamic and dorsal column / medial lemniscus. It senses vibration, pain, pressure, and proprioception, and light touch. And it goes to the somatosensory cortex in the parietal lobe. Okay, ventral-posterior medial. So VPL. So what about VPM? This is trigeminal and gustatory pathway, face, sensation, taste. Very pretty makeup goes on the face. Okay. Lateral geniculate nucleus is seeing. So cranial nerve 2, optic chiasm, optic tract, vision. Goes to the 1 degree visual cortex. Its lateral equals light. Medial geniculate, medial equals music for hearing. Okay, superior olive and inferior colliculus of tectum. And it's hearing. Okay, and then ventral anterior and ventral lateral nuclei are motor, basal ganglia and cerebellum, motor cortices, venous astronauts, vow to love mowing. Okay, so I want to make a note for this one. So this is note. Okay, this will also be a good one. Okay, cerebellum. Oh, these are good, but I want to get to the tracts. Cool. This is our homunculus. Okay, nice. Okay. Oh, circle of Willis. Willis, that's good. These are the exits. Oh, cranial nerves and arteries. These are also good. Like, I should maybe at least do the arteries. Oh, this one's good too. Descending is lateral cortical spinal tract. Okay, and the anterior cortical spinal tract is voluntary motor. And then you have also the ascending lateral spinothalamic tract for pain and temperature, which crosses over in the anterior commissures. Oh, perfect. The tracts. Okay. So this tract is a spinothalamic tract. It crosses over the anterior white commissure and then goes up. Okay. To the VPL. Okay, this next one is the dorsal column, is also sensory, but this one goes through the dorsal root ganglion, of course, but this one actually decussates at the medial lemniscus. Okay, and then the primary motor cortex, it decussates at the pyramidal discussation. Okay, perfect. So the only one really crossing over at the spinal level is the spinothalamic tract for pain and temperature. But vibration sense and proprioception actually stays the same up until the decussation at the medial lemniscus. And I guess also the motor cortex only decussates at the pyramids. Okay. That one is good. Okay, now I'm going to take a break. Okay, this was a good attempt at studying. Break time. Okay.